So today we'll be presenting our educational topic, a patient-centric approach to navigating medication use at transition of care. But before we do so, I just want to give you guys a little bit of an idea of who we are and what RevityRx does. A little bit about our backgrounds. I know that our bios were read, but RevityRx is a management consulting firm. So you have a better understanding of our experience in med management. Donna and I are both pharmacists. We're previous pharmacy directors for an integrated health system, and we've both led cross-functional care teams and have firsthand experience with the challenges faced providing high-quality patient care in a current healthcare environment. A little bit about our name, RevityRx. It's a kind of an amalgamation of two words kind of jammed together. The Revity component signifies our commitment to revitalizing care delivery, while the RX component identifies our focus on medication use. Our work spans acute and ambulatory, as well as population health domains, and we do emphasize our work in the transition of care space. We are focused on integrating med management into clinical and operational workflows. A little bit about our approach to medication use. We're guided by our medication stewardship framework. This is a relationship-based model, and it highlights the connections between the healthcare consumer or the patient, which could also be the payer, with the provider entity, which are the members of the care team that are delivering care, and the medication regimen. Our framework guides us to tailor solutions for our clients' unique needs, as well as meeting their strengths and resources. We also recognize that healthcare is local, and we need to meet our organizations where they are, use their existing talent, their processes, and their technologies. The capabilities that go into our med stewardship framework are agile by design to assist these organizations from moving from a foundational to advanced med use process. So basically, we can apply any one of these four foundational elements to any existing organization and help them either develop or mature their existing med use process. We basically have four main offerings. We start with our assessments, which we evaluate organizations for how they're currently operating and addressing med use issues. This could be in transitions of care, as well as other operational issue areas of their organization. We also do basic clinical consulting programs, which are engagement type projects, advisory services, and training solutions. If you're interested in learning more about our medication stewardship framework, as well as our capabilities, please feel free to reach out to Donna or myself directly at the end of this presentation, or please visit our website at RevityRx.com. Now I'm going to hand it over to Donna, and she can begin our educational session.
Thanks, John. Just going to grab this and we'll get moving. All right, so thank you, Mary, so much for that introduction, and John for sharing with our audience today a little bit more information about RevityRx. So let's now switch gears to the topic at hand, a patient-centric approach to navigate medication use at transitions of care. And I think as you heard, as pharmacists, our passion really lies in ensuring our patients are set up for success with appropriate medication use, especially at transitions of care. And this is such a vulnerable time for patients where the entire care team really needs to wrap themselves around ensuring that these transitions are planned in the best possible way, executed, and followed through. I think, as we know, regardless of which care setting you work in, you can have the best plan, but the moment it's not followed through or there's not another care team member helping out on the other end, it can crumble very quickly. So today's learning objectives are, we hope our audience will be able to walk away being able to explain the importance and complexity of medication use across care transitions, be able to identify opportunities in the transitions of care or TOC workflow where case managers can influence medication use, and be able to apply a patient-centric framework to prioritize TOC medication use activities. Throughout today's presentation, we'll be utilizing a survey tool called Slido for 2 specific polling questions. On the next slide, you'll see a QR code appear where you'll be able to scan it and just quickly answer the question at hand. And if you don't want to participate, no problem at all. But just as a reminder, we will be accepting questions throughout today's presentation. Doug will help us facilitate those during certain breaks within the presentation. So please enter your questions as we go along. Okay, this brings up our first polling question. What care setting most aligns with your current role? We're trying to really gauge the audience that we have today and get a better sense of if you're working more in the ambulatory setting, the acute care setting, managed care, population health, or maybe none of these settings really resonate and it would be other. I'll give it a few seconds to see if, how many participants we get up there before moving along. All right. Oh, interesting. All right, so it shifted a little bit. We have about 33% of our participants in the pop health space, acute care, followed by acute care and other, and then our ambulatory and managed care thereafter. So a nice diverse group tonight. All right, so I think the important piece here is with medication use and transitions of care. We have seen over the last 2 years that care is continually shifting from the controlled hospital and health system space to the ambulatory setting where there's less control over the care that's actually happening in the home and virtually. And so we've given these patients more autonomy over their care, but the support systems that we have in place have to follow. And so the patients, while they have to do a lot on our own, we need to ensure that our systems and processes follow to make sure they're able to be engaged and do that on their own, if not give them the right support services where needed. So that's really the impetus behind why medication use and transitions of care for us is an important topic to begin to hone in on as we see the care shifting to the ambulatory space. So to start with a little bit of background and give a little flavor of like, what are we seeing with medication use in the United States? Well, 80% of treatments for episodic and chronic conditions include medication. 42% of older adults, and we continue to see this rising, take 5 or more prescription medications. And of those older adults, 20% take 10 or more prescriptions. We also know that there's an inverse relationship that exists between patients taking a higher volume of medications and their adherence actually falling lower. So of patients that take 4 or more medications, only 51% actually take them as prescribed. And then this is probably one of the more daunting statistics where we really need to lean on. Of a 15-minute office visit, only 49 seconds of that visit is the provider really able to dive into medication education. And if we think about a patient starting on a new anticoagulant, is 49 seconds truly enough? And then where is that provider handing that patient off to? And so what does that transition look like? What environment are they going into? And so we need to think about this from the discharge lens too, from the hospital to the home. Are we providing our patients with enough tools, resources, and information to set them up for success? All right, so healthcare, as we all know, and which we're seeing from the audience today, is delivered in various sites of care between acute, ambulatory, population health spaces. But regardless of site of care, we know that our patients' payer composition really varies. So We see patients come in on government-sponsored programs like Medicare and Medicaid, publicly funded programs like state or municipal, employee programs, or even privately funded commercial programs. But what I think we're all hearing is that all of these are really moving to incorporate alternative payment models that are tethered to value of care. Hence, all of these organizations are really trying to address the fragmented and siloed approach to healthcare by really fostering and focusing on better care coordination. John and I firmly believe that medications are a really great place to look and can be a true indicator of an organization's degree of care coordination, since medications really weave throughout the entire patient's journey and throughout the care continuum. And we know that over 80% of treatments include medications across the country. So when we look at the ambulatory setting, care occurs in post-acute facilities such as skilled nursing or assisted living, as well as in the physician's office, pharmacy, or home, which we know has exponentially increased. And while the provider may decide to treat with the medication, it is really all of the clinical processes upstream. So upstream might mean prior to a patient receiving that actual medication product, or it could even be a process that might influence the decision to treat the patient with a certain medication. And we also need to focus on those clinical processes downstream after the patient receives the medication product. All of these are imperative to ensuring appropriate medication use in our patients. And so by building high reliability processes will ultimately result in higher quality care. So I mentioned the alternative payment models. I know there have been others introduced through CMMI that you might be more familiar with, programs such as the Centers for Medicare and Medicaid Services. There's programs around transitional care management, chronic care management programs. We're not going to dive into those today. However, we welcome a conversation after today's session if that's something that maybe your organization is beginning to delve into. The other important piece when we look at this visual is primary care is really critical to many of these services around care coordination and improving value. But I think regardless of the site of care we go to, the goal of all of these programs from payers and from our regulatory bodies are really to reduce readmissions, improve care coordination, and ultimately help reduce some of the geographic and racial or ethnic healthcare disparities that we see today. And so that's going to really require synchronous and asynchronous care. So this slide really begins to show the broad lens of the medication use process and some of the constraints and limitations that we end up being faced with. So when we talk about medication use process, there are a multitude of definitions out there, but it's important to simplify thinking about it, not just about procurement about the medication or dispensing of the medication, but really thinking about it more broadly of the point of determining whether there's a need to treat. Maybe the decision is to delay, or maybe it's to start, but regardless, we need to follow that patient through the treatment decision-making, the monitoring, the end, the continuation, and then maybe it's about selection of product based off of the payer mix. So I think we really need to make sure that we're thinking about it very broad and understand all the different work streams and activities that can impact the med use process. And so to go through this slide, there are several constraints and limitations that make the med use process and all of those various activities so challenging. You'll probably see that many of these are known areas in healthcare that we might face in other clinical processes or might impact other areas too. So when you look at these, you can look at them either from a discipline-specific lens, or maybe you want to look at these constraints and limitations from more of a team-based approach. Either way, it's important to determine the pains the individual or the team is feeling. So, for example, in our current healthcare landscape with staffing shortages, time becomes an even greater constraint, as there may be a significant imbalance in the capacity of an individual or team to support the existing workload. So what may then come into play is prioritization, or skill set variation may then have to be a trade-off. So when you start to look at it through what you're feeling right now, you'll be able to dive into the different constraints and limitations and where you might want to focus. Unfortunately, I think we all know, again, the fragmented nature of the US healthcare system makes implementing a very cohesive, seamless med use process very challenging. Silos do exist in acute and ambulatory. However, we are seeing greater silos now exist in the ambulatory care setting. This is largely due in part that in the acute care environment, the care team's known, they're often together or readily accessible. You're in more of a controlled environment and often with a captive patient or a patient that is present. Whereas in the ambulatory care setting, there's multiple sites of care. We have patients going into the office, having virtual visits, being at the home. We have primary care, multiple specialty providers, multiple pharmacies, and all having varied EHRs that don't talk all the time. And so connecting all of these processes and disciplines across all of those care transitions in that environment, when they're not under the same umbrella, can be even more daunting. On the bright side, and why we are so invested in the case manager role, is that case managers serve as such a vital care team member and are such great connectors that can begin to really help address these silos that we see and help break down these constraints of time, skill set, prioritization, even some of the technology constraints for other members of the care team. But I think, as I said, you can't do everything all at once, and not one person can own it all. So it's important to understand what you have control of, what you're able to synthesize with the information you have and where it goes. So understanding your role, your customer needs, and I think John will get into that a little bit later in the presentation. Sorry, I keep having a trigger finger here with the mouse. All right. So I thought this was an appropriate study to bring into tonight's presentation. Back in the beginning of 2023, the New England Journal of Medicine published a study titled "The Safety of Inpatient Healthcare." It garnered a lot of attention because it was the first time in a while that we had seen some data related to preventable adverse events. So in this study, Bates and colleagues described the results of a retrospective cohort study that addressed the frequency, preventability, and severity of patient harm of nearly 3,000 admissions from Massachusetts hospitals. Given the New England audience today, I thought it was a great study to share. And maybe one of your organizations even participated. So while this study assessed all potential adverse events, they identified that nearly one adverse event occurs in every 4 admissions. Specifically, my attention was drawn to the statistic that of the adverse events, adverse drug events were the most common, accounting for 39% of all adverse events during the index admission. The other thing, when I dug a little bit deeper into this study and the data that was presented, I happened to notice that out of almost 1,300 adverse events identified, a fourth of them were excluded due to them occurring at either another outside hospital during a previous index admission or during a previous outpatient encounter. And this really represents a significant opportunity, especially with care transitions. Unfortunately, our systems are often set up to capture events that have occurred in our site of care, and we don't have a great mechanism of sharing this information with other individuals in the community that we could partner with to really improve these processes and connect some of the dots where we might be seeing medications fall through the cracks during the transitions. So I encourage you to review this study. The citations included. I'm sure maybe you've seen it, and perhaps one of your organizations participated, and you have some learnings and some work to do out of it. All right, so let's shift gears a little bit into focusing on the role of the case manager. You heard John previously mention how at RevityRx, our business, we really focus on how entities can shift from reactive to proactive healthcare. And we hone in a lot on understanding the various relationships that exist. So the first step is understanding the relationship that exists between the care team, the patient, and the medication. And this really depends on the location that you're working within. But regardless of that, within each area, there's people, process, and technology that must be aligned to produce a seamless medication use process. And this doesn't happen overnight, but you have to start somewhere, and you have to understand that it's an iterative process of change, which involves the entire care team. So again, can't do it alone, and it's going to be an iterative process. But case managers really are uniquely positioned as this conduit of information between the patient and the care team. So as we see organizations begin to look for ways to improve outcomes with less cost, we really need to turn to our case manager colleagues, because you guys bring such value to the care team. Patients look for that longitudinal, trusted relationship between the patient and the care team. And this is truly a role that you can fulfill that includes components of synchronous care and asynchronous care, or those in-between moments where often case managers are the ones doing the outreach. So I think the important piece that we like to hone in on is there's value in care coordination, and we need to lean into that and make sure that it's happening outside of the context of a planned visit with a patient, and making sure that all the information that is getting obtained at any point within the patient's journey is getting to the right clinician at the right time. And so for today's presentation, we're placing the case manager in the care team member role. However, this same exercise we complete with other disciplines that are part of the care team. So I think it's important, first step is really identifying the case manager's role within the care team. What med use activities are you a part of? What can you impact? How do you prioritize these areas so you can support your customer and customers? And we're going to dive a lot into that further in the presentation. Okay, so we'll go a little bit more into the med use activities that really are a part of the medication use process. As the case manager serves as that conduit of information that's linking what's happening with the patient's medication in the uncontrolled home environment back to the appropriate care team member, it's important to understand what activity are they involved in. How can they recognize some of the anomalies that might be occurring with the patient during those conversations, and then exercise professional decision-making to determine if the case manager should act, delegate, or escalate. And again, it's not about owning everything on their own, it's identifying what you have control of and what other resources and care team members do you have access to. I do want to do a quick pause here, just in case there was any questions before I get into some granular details around the medication use activities.
We don't have any questions right now.
Great, thank you, Doug. I'll proceed. Okay, so earlier I mentioned that there's a lot more that goes into the med use process beyond procurement and dispensing. So this portion will introduce those activities and why medications are so important at transitions of care. All right, so I think we all know that experience, safety, and financial components in the healthcare setting are all integral and get pulled into a lot of the different discussions that you might have about roles, projects, programs, goals, and what you're setting out to do. And so just like many other things in healthcare, the med use process can have a significant impact on experience or satisfaction, safety, and cost, whether it be negative or positive from the financial aspect. When we look at experience, designing a seamless process where everyone can understand their role and that of the rest of the care team in the process can enhance job satisfaction. In addition, it can perpetuate greater communication during transitions. And so in doing so, when this happens the right way, the patient should not feel what is going on behind the scenes that is contributing to them getting the best possible care. But we do need to set expectations for our patients, especially now that there's often times where they need to be more highly engaged or there's more autonomy in what they're doing outside of the care setting. So communicate that. Set the expectation as to why they need to understand the medication information, why it's important, how it's going to be used, and the different steps that they can expect within the process. All of this will contribute to an improved experience. When we look at safety, I think we heard with that Massachusetts hospital study that preventable medical errors are still a leading cause of death in the United States. And at the time, a couple of years ago, nearly 1/3 of all medical errors were due to medication errors. We saw a similar number in that study, if not slightly higher. And I'm sure post-pandemic, we'd actually see some of these numbers creeping up too from the last few years. And if we want to put this in context, as far as like big numbers, preventable medication errors occur in 3.8 million inpatient admissions annually and 3.3 million outpatient visits annually. So it's a big number and something that we all are part of to be part of the solution. Then when we shift gears and look at the financial components, I like to lean in a little bit of the cost of rework. The cost of rework is significant, and there's a lot of waste that happens in our systems. So without well-designed processes, it's at the expense of some non-value-added tasks being completed or being done multiple times. I'm sure many of you have experienced or observed another discipline or colleague ask a patient the same thing or document the same thing again that's already available, or maybe there's conflicting information available. All of this rework really adds up financially, and if we have these silos, they're going to perpetuate rework if we're not communicating. And then when it comes to rehospitalizations, they continue to remain a common occurrence for most of our chronic conditions, such as heart failure, where transitions of care are vulnerable time, and medications play a large role in that particular condition, as well as many others. And I think the last time I looked, readmissions within 30 days of hospital discharge costs like CMS almost over $15 billion. So again, a very large number. So when we go back to this visual of the medication use process with the entire care team in the center, the key objective is to remove hurdles to bring the patient closer to the medication. So we really want to slide that together, decrease that distance so that the patient can really be set up for success. And so all of the med use process activities have some degree of a clinical, financial, or social component. These gray boxes that are beginning to appear all represent the hurdles that could come in the way. These first two can represent the clinical practice piece. So maybe there's involvement in collecting a medication history or completing a comprehensive medication reconciliation. It could be the development of the patient's treatment plan or ongoing therapeutic management. You might have to figure out what type of mode of patient education is needed for this patient, what is their health literacy level, and what are other special educational challenges that we need to be aware of that we can incorporate into our programs and our processes. And so I'll add a few more there. There's quite a few. But since medications really weave throughout the entire care continuum, these activities are all going to be impacted by some way, shape, or form with the care setting that all of us are working within. And so it really requires all of these care settings to come together and begin to build more integrated processes. I'm just going to go back a little bit to the comparing and contrasting of the acute and ambulatory environment. So in the controlled controlled settings like a hospital, patients captive, care teams close proximity, more formalized structure. In these settings, when we look at medication formulary, it's more limited, more closed. So this might limit the variety of meds that are available for use in the facility. This one tweak of the med use process can allow the care team to get more acquainted with the intricacies of the meds. However, on the transition of care side, it could also pose a risk from the knowledge space. So there's just different activities and different anomalies that surface in different care settings that we need to make sure we're accounting for. And then when we contrast the ambulatory space, the patient's often in their home. They might rarely not come into the controlled setting like a provider's office, only a few times a year, depending on how many comorbidities they might have. And so this just places such an additional level of complexity onto the care team that we really need to leverage each patient interaction or touch point as an opportunity. They need to be impactful to be able to make sure we're addressing those episodic care needs while also ensuring chronic care is on track. And so there's 18 individual activities here up on the screen in these gray boxes, far too many for one discipline to manage alone. However, they are consistently adding more resistance to close that gap between the patient and the medication. So as case managers, I really challenge you. You're such integral members to really, you're perfectly suited in this role and your broad scope to really begin to understand where within the med use process and within these med use activities that you can control. Maybe it's patient education, maybe it's medication access or affordability, or even keeping the medication list up to date. And I know it's a lot, and so you might be saying, well, where do I even start? And I think before we jump into that, John's going to go a little bit more into understanding who is your customer. So we need to understand who is the case manager customer, what do they actually need? So at this time, I'll hand it over to John.
Thanks, Donna. So the visual from the last slide really shows how complex medication use is. There's a significant number of activities. Some of them are occurring concurrently, others are sequential. And when we think about transition of care, we're adding in an element of urgency because we're preparing the patient for that next care setting. So in turn, it's really compounding the situation. So this places case managers in a position where they must prioritize what work needs to be accomplished. And the type of work they're doing could be direct, where they may need to act and do such thing as educate a patient or their caregivers as far as what their medications entail or how they're supposed to take a specific medication if they didn't quite understand the instructions they received from the previous care team member. Or their efforts could be indirect. And that could be they've discovered a new piece of information from the patient or their family member that might indicate a therapy change is needed, and it prompts the case manager to either delegate or escalate to a different member of the care team. So the scope and the type of work that the case manager is doing in the transition of care moment around medication use is really dependent upon resourcing, what information is available, and the unique needs of the patient. Really highlighting that prioritization is essential. And as Donna touched on earlier, we talked about who is the case manager actually serving? Who is their customer? And in these moments when we need to decide, do we act, delegate, or escalate? It's understanding what work is going to benefit who immediately. So this leads us to our second polling question. Who is the case manager's customer? So I'd like everyone to take a little bit of an opportunity and complete the poll and identify who in your line of work do you feel on a regular basis is your customer. And I'm seeing overwhelmingly a great number of people saying all of the above, which that is 82%. That's exactly the response that we were expecting to see. Now I see 18% say the patient, and your role may be directly patient facing or more in tune to what the patient might need. And ultimately the patient is our customer. But what we find is most of the work that case managers are doing, as well as pharmacists and nurses and other kind of members of the care team, we're really serving up information or other work for the providers or someone who could make an actionable decision to do something. So understanding who we're working for, who our ultimate customer is essential for how we prioritize what our work will be in the transition of care moment. So now that we're cognizant of who our customers are, I want to kind of target a specific component of med use. I know Donna had that kind of large visual up there. It showed 18 different activities occurring with medication use. But there's one particular component that has a real significant involvement in transition of care, and that's medication reconciliation. So what is medication reconciliation? I know we hear it said a lot. We hear med rec, we hear the term med history, and there's a lot of kind of confusion sometimes around that general nomenclature. Who's able to do what? I know that for a lot of our payer contracts, they do have kind of a med reconciliation component that's often completed by a pharmacist or a nurse or some other member of the care team. But I think the best way to think about this is let's look at a good working definition of what medication reconciliation is. And I think the Institute for Healthcare Improvement, or IHI, has the best kind of definition of med reconciliation. And while it explicitly calls out the hospital setting, I think overall the definition applies to all care settings. So they define med reconciliation as the process of creating the most accurate list possible of all medications a patient is taking, including the drug name, dosage, frequency, and route, and comparing that list against the physician's admission, transfer, and or discharge orders, with the goal of providing correct medications to the patient at all transition points within the hospital. And I think we can sub out that word hospital again to just say within the setting, because it could be in the home, it could be in a post-acute care environment, it could be at some other transitional moment at an urgent care setting, or just in an observational point of time in the ED. And one of the reasons that Donna and I really like this as an operational definition for med reconciliation is it calls to attention not having perfect information. It talks about the most accurate list possible. And I think if there's one key takeaway that we would like you to have today from this educational session, and really to relate that to transitional care, is that the med list is dynamic. And whether it's documented on paper or whether it's available electronically, it's a snapshot in time. And it's a snapshot of what the patient was either assumed to be taken or was confirmed to be taken at the time it was collected. So I think it's important that we take a look at the med reconciliation process and just do a quick review of what it entails, since it has the greatest amount of impact in the transitional care moment. So this visual reinforces the IHI MedRec definition, and it'll help us highlight the roles that each care team member plays. Now, the one thing I just want to point out is this is not an exhaustive explanation of med reconciliation. Med history collection, med reconciliation, they're really standalone topics. We can probably do a 1-hour session on each. Our intent here is really to just identify this as what it is. It's foundationally important to the overall process. We also want to highlight what the role of the case manager will play, and just recognize that this is a key touch point for the care team members to really discover and fix any medication issues. And this is important when we start talking about patients transitioning from controlled healthcare settings, like a hospital or a long-term care setting, or even a physician's office, back to a more or a less controlled setting, like the patient's home. So let's look at this and see what this actually entails. So med reconciliation is comprised of 3 distinct processes. The first 2, verification and clarification, we can bucket into med history collection, with the last actually being the med reconciliation step. And who can complete each step is really based upon what facility individuals are working in, as well as what your state regulations are in terms of individual practice capabilities. So for the most part, when we think about medication history collection, which is going to be that verification and clarification step, that's really work that our case managers, our nurses, pharmacists, and other trained technical staff can do. And we think about the reconciliation step, while that's really relegated to an individual provider, either a physician or an advanced practice clinician, or depending on what state you're in, if there's certain rules and regulations that allow others to have prescriptive authority, they can really complete that step. And what the literature supports is that individuals who are working and designated to do that work on the verification and clarification component that differ from the individual doing the work on the reconciliation component, we are set up for a much safer system because we remove the confirmation bias. I'm sorry. So the main thing that we want to kind of highlight here is, why is this all important at transition of care to the case manager? And what should we really do with this information? So the main thing is, we're not saying that case managers should be completely responsible for collecting that med rec information or that med history component, those first 2 buckets. Instead, we find that it's crucial for the case manager to understand what their organizational processes are and policies and workflows for med rec, their specific role, and then to have a working knowledge regarding what the information flow looks like between settings. It's also suggested that case managers become a little bit more fluid or accustomed to developing a good med history collection process, and they will have an advantage when it comes to addressing med use issues at transitions of care. Being comfortable with not just accepting what you might see on a list or documented on the computer within the EMR is just good practice to question what we see. So if anybody is interested in having quick tips or tricks for collecting medication histories, please feel free to reach out to Donna and I at the end of the session. We do have some tools that we can share to kind of aid in that. But now that we have established that the MedRec process is foundational, I want to move into more strategies that the case managers can use to better navigate transition of care. And we're going to have, our goal will be threefold here. First, we want to simplify the complexity of med use and promote high reliability. So we want to take that last kind of visual that Donna presented with those 18 different kind of med use process activities and figure out what we need to focus on to really make this simple or simplify it for when we're in that moment. Second, we want to ensure our customer needs are met, regardless of who that customer is, whether it's other members of the care team, the patient directly, or even the payer. And lastly, we want to deploy a patient-centric approach. So with that, we've identified 3 areas where case managers can positively influence medication use at transition of care. And I want to just start by saying that this is not to place more work on the case manager. This is more of a means to kind of help prioritize what work we should be focusing on. There's simply too many transition of care coordination activities that the case manager needs to resolve. There's things like lining up outpatient visits, coordinating maybe durable medical equipment, even coordinating transportation from one care setting to the next. The medication use components, whether that's prior authorizations for certain medications or working on some affordability issues. And then there's other social determinants of health type components that the case manager is working on related to food, housing, and other needs. So instead, we see these buckets as more of a strategy to prevent the case manager from being sidetracked from medication use issues. And it's a way of thinking or bucketing whether or not the case manager really needs to be the one who acts, or if they can delegate or escalate to someone else. So let's take a look at some of these buckets. The first one we have is in-between visit management. And what this basically is what does the patient or the care team need to successfully bridge care to the next care setting? The next bucket we have is health literacy. And this is really getting a good understanding of, is the patient or their layperson caregiver capable of understanding their medication regimen, especially when they leave that controlled environment and move into the home setting where they're going to more than likely be on their own for the majority of the time. And then lastly, we have Revity, we use this term, we talk about the 4 A's of med use as a way of kind of thinking through med use related problems. And that really focuses on adherence, accessibility, affordability, and awareness. Now we'll get into each one of these buckets in more detail in the next few slides, but what is important here is understanding that deploying this strategy emphasizes the case manager's relationship with the patient. And as we have written on the bottom of the slide here, we know that healthcare is fragmented, and we also know that medication use is complex. What Donna showed early in our presentation about the number of patients taking medications on a regular basis for either an episodic or chronic condition is very high. And then what we saw is patients as they take a greater number of medications, 51% of them begin to not even take the medications at all. So we know that medication use is complex. Lastly, we will leverage that relationship because it's essential that the care team uses the case manager and their intimate understanding of the patient's needs to make sure that we're addressing these issues as they come up, again, at that transition of care moment prior to the patient leaving that controlled setting. So let's take a look at our first strategy, which is in-between visit management. So case managers really, again, are the link for patient care in between visits. And it's important that we understand what's happening, not just from a general kind of like overview at the level of transition of care, but what's happening locally in your organization or actually in your setting. Who is managing what? That understanding this information will be important when we need to move into our kind of act, delegate, and escalate framework. And then lastly, understanding that there's no real one-size-fits-all solution. We're working within a framework, but every patient is going to be unique, and every situation will likely have some sort of scenario that we may need to make some judgment calls on. So we think by thinking in this kind of bucketed approach, it will help us move to a better decision-making process and be more reliable in our outcomes. So in between visit management, what should the case manager identify? Well, here we're really looking for changes in home medications, allergies, and other relevant labs. And when we say that, it's kind of like the high level things that might go missed, things that we can draw to the other care team's attention, kind of as that last kind of safety net. And when we think about this type of information, why is this important at transition of care? Well, when we think about medications and at the moment of transition of care and how fragmented our healthcare system is and the siloing of our different EMR systems, there's really no universal cross-platform for a medication list that currently exists. Now, I'm not saying there's not one that they're trying to develop, but currently we do not have a universal med list. So if you have your PCP doesn't necessarily see what the specialist is prescribing if they're not within the same network or same kind of ownership, just as well as your provider may not necessarily see what was actually filled in a community pharmacy or a mail order pharmacy, and vice versa. Those pharmacists may not see those dispensing either. So the case manager really plays an important role at this point of helping to identify what those changes might be. The other rationale behind why this is important is when we're talking about transition of care and health status changes, we often see an impact on medication use. Patients don't come in the hospital because they're doing well. They come into the hospital because they've had some sort of event, either a decompensation of their current disease or some other kind of acute event. And when they leave the hospital, it's typically because they're on the path to either improving or moving to a different type of acuity level that will better suit their needs. So I just wanted to kind of address a little bit about the fact that with the universal cross-platform medication list. And I know that a lot of our case managers and our provider offices, as well as other organizations, our hospitals, we have EMR systems. They have some sort of med history tool. They're often linked to e-prescribing software, which e-prescribing is definitely more prolific. I believe the last statistic I saw is somewhere in the range of 90% of prescriptions are prescribed electronically. So we capture a lot of that information, but it's not foolproof. So these tools that we're seeing collecting med history, they do have some gaps. And vendors are getting much better about gathering as much information as possible. Some are leveraging artificial intelligence to try to cull those lists so that duplications are removed, so that the actual care team is seeing the information in a more usable, presented manner. But I think the one thing I want to highlight is those tools do have some gaps. Prescriptions often filled in the retail or community environment that are not processed through a third-party program. So if they're not billed through the patient's, let's say, insurance plan, may not show up on those lists. Prescriptions that come from like a long-term care facility or assisted living facility often don't populate this list, as well as physician samples given from the office. So the main thing I just wanted to kind of talk about there with those kind of tools is they're helpful, but they're not 100% complete. And this is where, when I mentioned about med reconciliation and the med history process, this is where becoming more fluid in collecting med history would be very, very helpful. So last thing we have in the in-between visit management is the act, delegate, or escalate. And I think the main piece that we can kind of emphasize here is really developing workflows for med history and allergy collection, as well as being mindful of what labs impact the patient's health conditions. And if your organization doesn't necessarily have workflows in place to do that, professionally, you should be thinking in that framework and helping your administration and leadership maybe move to a position where they'd be interested in developing those type of workflows. So how would we put this into action? And I would suggest the best way to put this kind of in-between visit management into action is to take a segmented approach. and divide into three kind of components listed as the day of the transition of care, what's going to happen days 1 through 7 post transition of care, and then what's happening days 8 through 31 post transition of care. So if we think about that and this in-between visit management in these segments, and if we use, let's say, a patient case example of someone who had their first acute myocardial infarction and they're being discharged home, there's a high likelihood they're going to be placed on at least 4 or more new medications. So if we're thinking about in-between patient management, on the day of transition of care, we can be asking ourselves these questions are, will the patient have all their new medications available to them at the time of discharge? What services are available to help ensure this happens? And are there some issues, let's say prior authorization, affordability, or other coverage issues that we may need to address? So this is where on the day of transitional care is really understanding how can I help this patient or members of the care team move this individual to the next care setting in a very seamless manner. Then when we think of the next kind of segment, that day 1 through 7 post transition of care, it's if there was a prior authorization, who's responsible for ensuring that prior authorization was completed or being followed up on? And are there other medication coverage issues that may need to be resolved? These are all pieces that we can begin to start handing off or communicating out to the next individual in that chain of kind of care continuity. And the other piece is the patient going to be able to understand their self-monitoring? So when we think about that day 1 through 7 post-discharge, and if we have a follow-up call with that patient within 72 hours, did they really understand what they were supposed to be doing? And are they able to assess if they're doing okay or improving or just meeting what the expectations of their care plan would be? And then lastly, the segment we would have would be that day 8 through 31. And one of the emphasis that we like to have is we always like to talk about day 31. And the reason we bring up day 31 is often when a patient is discharging from an acute care setting or even moving from a post-acute care setting, maybe to the home, there might be some coverage issues with their insurance plan. They may be set up on a trial card program for a specific, let's say, high-cost medication. They get a free 30-day supply, but that 31st day out there, they may be left without medication. So one of the pieces we want to make sure is, do we have a plan in place to make sure that this patient will be successful, not only for that second week of the post-discharge, but what's happening on that 31st day post-discharge? So there's a lot of information there to unpack, and it's definitely an area where the case manager has a lot of involvement simply because of the relationship that they're building with the patient and their care team. The next area that we see as a bucket where the case managers can focus during the transition of care moment is really assessing the patient's health literacy. And with care shifting from the controlled setting to a less controlled setting at the home, patients must understand their medication regimens in order to use their meds effectively. And this is something that we see emphasized over and over and over again. And a lot of the social determinants of health issues address health literacy, but this is one component where we can really look at specifically around med use. Does the patient understand what they're supposed to be doing once they get their medication? And what should the case managers identify in this situation? Well, what is the patient's fluency just with their therapy and their goals? Can they even identify what a medication is being used for? Do they know what they're supposed to expect? If their medication is for, let's say, a blood pressure medication, are they aware of that? Do the family members or the patient themselves actually know the names of the medications? That would be alarming, and it should be an indicator that there could be some health literacy issues there if patients are even unaware of the type of medications they're on, meaning the classes or the names of the medication. And lastly, are the patients even aware of where their medications are coming from? Are they being dispensed from the local pharmacy? Are they coming from a mail order service? Things like that could be clues that the patient may not have adequate fluency with their own care and might require some intervention on the case manager's part to help with that component, whether it's acting or delegating or escalating to another member of the care team. So why is this important then? Well, what we find with health literacy is that it really impacts other utilization, and it with poor health literacy, we see higher use of urgent care, higher use of the emergency room, increased use in hospitalization altogether, and poor treatment plan adherence. Ultimately, it leads to higher mortality rates. So something as simple as just asking if the patient understands or using a specific method to kind of gauge that can really help improve this in the long run. And when we think about medications, they're the primary treatment options. And we need to understand, make sure that patients and their caregivers understand and comprehend their therapy and their plans. And when we think about case managers and the act, delegate, escalate, it's really just helping recognize what those disease-specific clues are that indicate there's literacy, health literacy opportunities. So if we put this into action, what can the case manager do? Well, if we're not working within a specific disease state, as far as like diabetes or AMI or congestive heart failure, there's a lot of information that has to be known. So the key piece is really becoming knowledgeable of what your organization's resources and tools are to assist patients with health literacy needs. Deploy certain strategies like teach back. When you're talking to a patient, use very approachable language and then have them teach back to you what you just told them. Did they understand what was said? Are they able to comprehend that? Did it make sense? If not, maybe need to look for the different tools that might be out there and available to us, either using printed visual aids, if there's access to certain videos. A lot of organizations now have links to different health education platforms where we can actually send patient a video of their meds. This is very helpful in the case of individuals who might have like COPD and are unsure how to use one of their inhalation devices. There's also apps out there who can help guide the patient around certain disease states. The American Diabetic Association has apps around diabetic care, as well as the American Lung Association around COPD care. So there's a significant amount of information that the case manager can use or do to help the patient with health literacy. And then lastly, I want to talk about the kind of 4 A's of med use, or our other bucket. And this is somewhat of a kind of more targeted bucket, really looking at the kind of ambulatory space and setting that patient up when they leave. But adherence, and we hear a lot about med adherence. It's a large component of the Medicare Advantage plans. It has very significant weighting for a provider as well as the payer's STARS ratings. So there's a lot of work that happens around this. But we see adherence as really what linked in what we call the 4 A's, where adherence is really equal to access plus affordability plus awareness. And when the A's don't add up, patients have poor outcomes. So what is the case manager supposed to identify around the 4 A's? Well, sometimes asking direct questions to the patient, like, do you take your medication, will often elicit them to say, yes, I take my medication. So we need to start thinking a little bit broader. Are there social determinants of health issues? Are there care fragmentation issues? Meaning, is the patient receiving, let's say, a specialty medication that's going to come from a separate specialty pharmacy, or do they need to go to a special infusion suite in order to have a medication administered? That could be problematic from some patients, and it could be an indication that we need to have a little bit more of engagement with them. And are there communication gaps? Is the patient going to go to a primary care office or a specialty practice that's not affiliated with the organization that they just left? So there's a likelihood that records may not immediately transfer over, or there's a communication issue between the patient and the care team that requires the use of a translator who may be a family member, and that family member isn't always available. These are things that we can just kind of think about and help us to identify maybe one of these A's are affecting the patient's ability in order to be successful with their medication use. And then why is this important at transition of care? It's just that medications, as we talked, they're used 80% of the time to treat disease. And if we're thinking of the ACT, delegate, and escalate, it's really about developing workflows that are inclusive of the entire care team and external partners. I think the main piece is then, you may ask, shouldn't the pharmacy or the other providers really handle medication adherence? And I think the thing there is they do. And I talked about those med adherence ratings being important to the value-based care programs, and the providers and the pharmacies, they're rated upon that. But most of their interventions are reactive, and they're largely focused on doing things kind of on a brute force approach, where there's aggressive outreach to the patient. There's a text message or phone calls, some sort of notification strategy that's really targeting patients that forgot their medications, or patients basically stating that there might be an outright unwillingness to take their medication. But for us, this really prompts another question. And it's, does medication adherence matter to the patient? And it's probably not as much as we think that it matters to the providers and the payers. And part of the reason behind that could be related to friction in the patient's ability to actually obtain their medication. So for our job, it's really to look beyond what we would be considering the behavioral causes of adherence issues and look for components where we can say there's friction points that the patient may not be able to access their medication in a timely manner. So for putting this into action, a key is to really be more patient-centric, thinking about what's happening. Are there changes in the patient's prescription drug coverage that might dissuade them from obtaining meds? This could be seasonal. As case managers, understanding how insurance plans work through the point of like prior authorizations or even deductibles and copays, it's seasonal. And this is input that we can have into drug selection to the providers and other members of the care team to really help the patients along. Is the patient obtaining prescriptions from the prescriber in a pharmacy in a time? Is there timely communication for refills? Meaning when they need prescriptions, are they getting them refilled in a timely manner? Or is there a lack of communication between those two areas? That's a friction point that may not be seen when we're thinking about that kind of brute force outreach for adherence, but it's something the case manager may be able to uncover in just discussing. Are you having challenges getting through to your physician's office to get your medications refilled in a timely manner? Also, is there an issue with drug shortages? Patients are often a little resistant to explain to their providers that they're unable to get their drug, and they may not be able to kind of acquire the drug from the pharmacy. This is something the case manager may be able to kind of get out of the patient through their interaction with them in this particular process. Ultimately, the way we look at the 4 A's of med use and medication adherence is it's a poor adherence is really a care coordination issue. And our initiatives really need to be around prioritizing and identifying areas where access, affordability, and awareness can be sought out proactively to provide a better solution. Now, I'm going to hand it back over to Donna so she can go through and summarize and highlight some key takeaways from our presentation.
Great, thank you, John. So for time's sake, I'll try and go through these next few slides pretty quickly. So we started today's conversation really with the complexity of the med use process. And in the beginning, this visual was a big tangled web between all the different sites of care and the work streams that were happening. But I think the intent is that as we begin to make these more seamless, which is an iterative process, we begin to see this untangle to improve medication use. There are, I'm sure, many great things that each of your organizations are already doing that you can leverage to really lean into beginning to simplify this. So maybe you already have a structured, formalized medication reconciliation program where each discipline upstream and downstream knows their role within it. John mentioned some communication strategies and educational tools such as TeachBack that can actually be integrated into all conversations. And maybe your organization has some degree of a discharge prescription program that could be accessed for populations that are most at risk, if it's not for all populations, that begin to bridge that gap in the transition of care space. But again, let's not forget about day 31, which is very important to us. And then we talked a lot about customer needs. Who's your customer? What do they expect? So as we begin to lean into our roles, individual roles, and being able to anticipate those downstream customer needs, you'll be able to integrate better pieces within your own process that will be able to share and create more integration and seamlessness. I know you probably heard us harp on this quite a bit, but I think ultimately we're very much about engaging the entire care team in the med use process and making sure that the key is being able to identify what you're in control of, what you can actually impact in your current role, and then what you prioritize to then be able to share with the rest of the care team, either that you've acted on something, you've delegated something to another care team member, or you've escalated it to the appropriate clinician. I do challenge you after today's session to do one quick exercise. If you go back to the slide that showed all of the various constraints and limitations in the med use process, it's really easy to just sit down either individually with your team or with one of your leaders to work through one of the med use process activities that you're involved with and begin to think about the pains that you're feeling within that process. I promise you it will elicit some opportunities that could be quick wins within the work that you're already doing. And all of this will begin to help untangle and allow you guys to be part of the solution to getting our patients to better outcomes. So our three key takeaways for today's presentation is that med management during transitions is a significant area of opportunity and very vulnerable for our patients today. It impacts safety, experience, and financial aspects of care. It's important that organizations are moving in the direction of developing high reliable transition of care processes that have really good governance structures in place, ensuring that there's care team capabilities and technology all aligned across the care settings. Excuse me. And last but not least, is making sure that we're not doing everything, but we're prioritizing the activities that fall within our role for the case managers in this situation to begin to delineate the acting, delegated, and escalating, and balancing the needs of the various customers that you might have. So we thank you very much for your time this evening, and I apologize if we went over a little, but at this time we'll welcome any questions from the group.
Your timing was perfect, Donna. I don't have any questions in the Q&A now. If anybody has